It is a huge honor today to be interviewing my bald, beautiful brother, Mark Bose from South Africa, who's a legend in cosmetic dentistry, implantology. I've heard about our friend Ken Sirota thinks you're just probably the smartest cosmetic dentist he's ever met in his life. How are you doing today?
I'm doing really well. I have to say, we're a couple of hours ahead of you guys in the States, and I've had a full day, a good day, a busy day actually.
Well, it's 11:30 in the morning here on a Wednesday. What time is it there?
It's 8:30 in Cape Town.
8:30 p.m. on Wednesday.
8:30 p.m. here in Cape Town. So again, it's a pleasure to be interviewed, and I'm so happy to have this opportunity just to share some of the stuff that happens down in South Africa.
Yeah, and you were what, 20 years in England too, correct?
I spent 23 years in private practice in London, and then decided that I needed to come and sample some of South Africa. You know, I obviously qualified and grew up in South Africa, so it's been great to come back and share some of my experiences that I learned in Europe when I was living in London.
So do you ever get back to London?
Sorry, I didn't catch that.
Do you ever get back to London?
Yeah, I go back for some meetings, and I've still got obviously lots of friends out there. So yeah, I get back pretty much every year. I don't miss it, though, I have to say. We live in the lifestyle capital of the world, Cape Town.
And why is it considered the lifestyle capital of the world? So much outdoors stuff?
Yeah, we just have outdoors. I mean, it's really an outdoor playground. You know, we have mountains, we have sea, we have weather, we have kind of everything that you could wish for if you like the outdoors. So it's a great place. It's kind of a small city. We don't have traffic, and it's a great environment to work. Lots of cool people, and it's got a kind of international feel. So you know, coming from London.
I shouldn't ask this. This is rude to ask, but I might as well might as well do it. So, what did you think of the that whole international deal about the dentist from America going over to Africa, Zimbabwe, and shooting a lion, Cecil the lion?
Yeah, I mean, I think that we've had a big campaign against this sort of call it canned hunting. Hunting in South Africa has been around for a long time, but I think we've got to a point where commercially and sort of I think that it's kind of not acceptable anymore on this sort of scale, and it's a fine line between what's allowed and what isn't. And I think lions are pretty cool things, and I don't think we need to shoot them and put them on our walls anymore. I think those days are over, really. I mean, I haven't got a massive opinion. It's more of an opinion on not him or the whole thing, but it's is it a good thing or is it a bad thing? I don't think we need to kill these things anymore, to be honest.
Yeah, I thought it was really gross, personally.
Yeah.
And I like the way you called it canned hunting, because it's not really hunting.
No, they lure these guys in. There's no skill to it, to be honest with you.
Yeah.
And so in the good old days it was tough. It was kind of an equal fight, and most of the time you didn't actually pull it off. So yeah, I think it needed to be brought out in the limelight. It was unfortunate for that poor guy, but it was going to be someone, and the media, social media, were going to jump on it big time.
Yeah, deer hunting and elk hunting is big in Arizona, and I've gone several times. I just to watch or take a picture or camera or anything, but I could kill a cow. I mean, I'm a big hamburger guy, but if you're not going to eat it, it doesn't make sense. But hey, I want to ask you something that's probably you won't would have the international flair for. Is there a difference in cosmetic dentistry around the world based on customs? Like I've often been told by many European dentists from Russia, Poland, London, that Americans kind of they like their teeth too white, they like their breast augmentations too big, they kind of look more clown-like in the United States. Is there a difference in what a woman finds attractive in cosmetic dentistry from Cape Town to London to the States?
I think subtle differences exist, but really we speak the same language. I had an interesting situation. I did a roadshow with a very good friend of mine from Budapest in Hungary, who's one of the top cosmetic surgeons, dental surgeons in Europe, no question. And we prepared lectures, and we hadn't exchanged notes. And really what we found is that the things we were saying were absolutely the same. I think the subtle differences exist where certainly I see on social media, some countries kind of like bleached 2 and some like bleached 4 and some go for A1. But the principles, the protocols, the way we do it, I think there's no real difference. The materials and the responsibility that we have to our patients, I think, is the same.
I don't like to talk about anything that everybody already agrees on, like 2 + 2 = 4. That's why I like to ask the controversial ones, and I don't think I could have got more crazy than opening with Cecil Line. But I want to ask you another very controversial aesthetic dentistry question. It seems like when it's the doctor's own daughter, it's always orthodontics, bleaching, and maybe some additional direct composite. And then when it's just some stranger off the street, it's peel off the enamel on the front 10 teeth and do veneers. Do you see where I'm going? Do you see any of that?
I don't see where you're going. I see it every day. It's a massive problem. I think this is something that the last roadshow that we did, we really just talked about minimally invasive dentistry, about another way of doing it. I have a great saying, you'll like it. You live by the burr, you die by the burr. We learned to cut teeth, and it's kind of what we like doing. But really, we have a massive responsibility to our patients. Not only to do it a different way, but also to explain it to them. I think that the term kind of controlled failure comes to mind. In other words, we have to be honest to ourselves and our patients that everything we do is most likely going to fail. And it's a mere matter of how long it's going to last or when it's going to fail. And, the important thing is that kind of if it fails, there has to be another option. And when I look at the dentistry that's still being done today, failure is often catastrophic, and that for me is a problem. So I think it's kind of educating not the dentists how to do it better, but also the patients what they need from us. So I totally agree with you about the daughter thing,
And I'm 53 now, and my boys are, I have 4 boys, 22, 24, 26, 28. And I want to tell those kids that just graduated dental school last year that when you go to these cosmetic dental lectures, they don't show any of their failures. They don't show a case where they did 10 upper veneers and 20 years later, some of the teeth died and needed a root canal. They're often photoshopping these pictures and slides that you see on Facebook and all that stuff. But since they never ever show failures, and you have enough high self-esteem to talk about failures, if you prepped 100 women for 10 anterior veneers like we did back in 1987, taking a millimeter and a half off, 20 years later, if you did that to 100 women, how many of those teeth would have died and needed a root canal or a full coverage crown or?
Put it this way, there's some really cool studies out there. And the one study that I looked was done by some Scotsmen, some Scottish guys, Saunders and Saunders. And what they found is they just had a look at a huge number of Panorex x-rays. And they found that 20% of crown teeth had periapical disease. So there's kind of a figure, that we can think about.
Did you know
way too high.
It doesn't surprise me that the Scots published that. Did you know they invented wire?
Yeah.
It was when two Scottish men were fighting over a penny.
That's a great. That's very cool. It's a massive percentage. Even one for me is too many, to be honest with you. Whether it's 1 or 20, 1 is too many.
So how many years have you been doing cosmetic dentistry?
I've been doing cosmetic
dentistry.
I've been doing cosmetic dentistry for more than 15 years. My practice now is limited to aesthetic dentistry. It's interesting, I suppose, that we talk cosmetic dentistry. The one thing that is different in Europe and America is kind of in Europe and in South Africa, we kind of follow the Europeans a little bit more, is we like to talk more about aesthetic dentistry than cosmetic dentistry. But I think it's the same thing. I don't know how you feel about that terminology.
Right.
But the last 10 years, pretty much, I've limited my practice to aesthetic dentistry or cosmetic dentistry. Sorry.
So you're probably being listened to by about 7,000 dentists, probably 80% of the United States, 20% the rest. All 206 countries that we track download each episode. What low hanging? You don't have much time. You only get an hour with these guys.
That's right.
What low hanging fruit do you think you could tell these guys? But by you specializing in and have done it for so long.
Sure.
What do you see day to day that you think these guys and gals should be thinking about as they're commuting into work?
If I look at my practice and I think about what's kind of changed, the dynamics of what I do now that I do differently, the first thing that comes to mind is magnification. You know, you have to work under magnification. That's not negotiable. You know, it's not possible to do the dentistry, and my eyes are the only part of my body that still work properly. But, you know, that's not negotiable. So, you know, I have a joke, actually, when a patient's looking for a dentist. I say, if you go in your first consultation and you notice that the guy doesn't wear loops, then maybe you should think twice about the next appointment. But, you know, I think in this day and age, you need magnification. The second thing that's changed massively for me is orthodontics. You know, is incorporating orthodontics into every treatment plan that I can where possible. You know, so move a tooth rather than drill the tooth if that's going to achieve the same result. So, you know, that's kind of, you need to up your orthodontic skills, no question, or your orthodontic diagnosis. Whether you do it or not, it doesn't really matter. And I think that, you know, I think you need to understand adhesive dentistry. You need to understand the bonding protocols. You need to understand rubber dam, those sorts of things that go hand in hand. So kind of in a nutshell, magnification, orthodontics, and understanding adhesive dentistry, you know.
You know, one of the things I see that my biggest critic of veneers or anterior crowns or aesthetic dentistry, I think aesthetic, is the aesthetic the French word and cosmetic is the British English word?
Listen, in England they've got both an aesthetic academy and a cosmetic academy. I think kind of one that is a little bit more commercial. So the cosmetic is a little bit more commercial, but they mean the same thing. I mean, it's the same language.
Ryan, can you check that? I think aesthetic might have French word, but one of the things I see, what you said about orthodontics is a principle often abused in aesthetic cosmetic dentistry is what we were taught, the BMW, the biological minimum width. And a lot of times when you have crowded teeth on the front that you're shaving down for veneers, if those roots almost touch, there's not enough bone there to be healthy to have a defense against periodontal disease and pathogens. And you need about 1.5 millimeters bone in between those anterior teeth so that they can survive when the patient's going to be 50, 60, 70, 80, 90. And so unraveling it is a better long-term. I love what you started with as dentistry is controlled failure. I mean, live by the burr, die by the burr.
That's the way it is, you know, in simple terms.
And I want to get specific on adhesive dentistry because I still think the biggest mistake I see in adhesive dentistry is dentists are smarter than these billion-dollar companies, and they mix and match materials. They use a bonding agent from this company and adhesive. You know, they mix and match, and I think I always see humility. The number one trait among successful dentists. They listen to the manufacturers, they listen to their patients, they listen to their staff. And so many dentists are arrogant. And it's like, okay, so this was invented by like 3M, and they have like 60 PhD researchers who have PhDs in organic chemistry, but you know more than them. So you're mixing and matching the deals, and you just know everything. And so what exactly do you use in adhesive dentistry? What product? What bonding agent? And why?
I tell you, I mean, are we going to talk about cements or are we going to talk about adhesive? I mean, if we're talking about cementation and we're talking about, because a lot of what we're chatting about now, veneers, porcelain, and bonding, you know, I think that I'll mention one other thing that is key to controlled successes rather than controlled failures, but is enamel. You know, there's no question. You know, I mean, it's enamel, the enamel of the tooth. You know, we have to preserve it. You know, whether we move the teeth and then prep it, there's so much research out there. There was a great paper that was done by a very good friend of mine, Philip Gurel, and Christian Coachman and Kalimata, and they showed absolutely, without doubt, beyond doubt, that the longevity of these restorations depends on the enamel that we're bonding to. You know, it is the most predictable bonding substrate to bond to. So, you know, we need enamel, that's for sure. My preference these days is the universal bonding systems, because it allows us to make a decision whether we go down the total etch, whether we go selective etch, or whether we use the self-etching adhesive system. So it gives you great flexibility. I think it's taken a lot of the confusion out of all the bottles, and I think the bond strengths are without doubt as strong as they need to be, particularly if you're preserving enamel. You know, I think that's the kind of key to the bonding systems that I like to use.
And which brand are you using?
At the moment, for my cementation, I love the new Ivoclar products. I have to say, the Prime Etch and Bond and the Aesthetic Cements, Dual Cure, Light Cure. It's such a simple process. You know, when I used to bond veneers, you know what it's like. You know, we had umpteen bottles all over the place, and you had to really, you know, get your mind in gear about, you know, whether you had put this liquid on for this long, and then you had to rinse it, dry it, put it in an ultrasonic bath, then clean it, then wipe it, then blow it, then spray it. It was really almost impossible to get this whole process right. They've simplified it, and again, you're right. I mean, I trust the R&D from these companies. You know, I think you can't look at something and say, well, you know, it looks too simple or it's not going to work. I mean, obviously, a lot of these products, you know, we need to wait 5 or 6 years down the line to see, you know, what is going to pan out. But I think that, you know, their R&D departments of the likes of Ivoclar and 3M are going to do good research for us. So these days, I had to say, I used to use the 3M products. I think it's a fabulous product. Again, a universal bond, the Scotch Bond Universal, and the Reliax Ultimate. But I've switched because I'm a big Emax fan. You know, I mean, you know, if I'm going indirect restorations, I'm an Emax fan. I'm not getting paid by them, sadly, but it's a great product. There's no question.
Now, you graduated from dental school in '81, right?
Yeah.
In University of Witwatersrand. How do you pronounce that? Witwatersrand?
Witwatersrand.
And where was that? What country was that?
It's in Johannesburg, in South Africa. It's
That's
where
in
we're going to
Johannesburg?
be. Yeah.
Because walking these, you know, a lot of you, the listeners weren't born then. I'm sorry to say. When you go to these dental school classes, the thing that every time I go into the lecture in a dental school class, I'm always thinking it before I get in there. I'm always going to think, okay, now don't be shocked when you see how young they are, you know, because every time you walk in there,
listen.
Oh my God, I always walk in there and think, oh my God, you guys are going to be doctors in a year. You look like you should be on a swing set on a playground. But walk these kids back to that journey, because when we started doing cosmetic dentistry in the 80s, there was a lot of sensitivity from bonding. And a lot of these instructors were saying that it was all our fault. We didn't have the rubber dam on right. We put too much or too little. We dried it too much. We didn't dry it enough. It was always our fault, and we all believed it. And what I did is I started going to these dental lecturers who never had any sensitivity. I started going to their dental office, and then while they were in the middle of the procedure, I'd walk up front of the receptionist and I'd say, you know, show me, you know, I started looking up records. And I started asking the receptionist and calling patients, well, did you ever have any sensitivity? And they'd be like, oh my God, I was eating ibuprofen for 6 weeks, and I quit taking ibuprofen because my diarrhea from the ibuprofen was so bad. I had to decide what hurt more, my mouth or my butt. And then I'm going back and say, that's amazing. You just lectured to 300 people and you never get any sensitivity. And every single person I call, and some of these people had got refills on Vicodin 3 times. So, but it really changed. The chair side chemistry set changed. The sensitivity went away.
Yeah.
So to me, I thought it was.
Yeah.
I still believe. I'll always believe it was a manufacturer problem in the 80s and the 90s, and then they solved it. Do you agree?
Yeah,
Do you agree or disagree with that assessment?
no, listen, I agree that, if I just think back over the last 2 years that I can think clearly about, there's no question. I wouldn't say I don't get sensitivity, but I literally can't remember the last time I had sensitivity. And for sure, the bonding systems are much better. We can seal the dentine in a much better way. We understand the process. Yeah, I mean, I think that there's no question our products have improved dramatically.
So what is the microscope behind you we see right now?
This one here?
Yes.
Yeah, it's just a little toy of mine for seeing better. It's the magnification we talked about.
What system is that? I can't read the blue.
Oh, it's a microscope called Zoomax.
Zoomax, ZOOMAX.
No, ZUMAX.
Okay, and what magnification do you like with that?
I have to say, I don't do any endodontics because I do such good minimally invasive dentistry that my need for endodontics is almost gone. And interesting, there was a conference just recently in Europe. I think it was done by Pascal Magna, and the whole theme of the conference was a world without root canal treatments. And they were talking about minimally invasive dentistry. And so, I kind of like to work between 5 and 8 times.
And that is just amazing to be able to see something 5 or 8 times larger.
I mean, it's another world.
Oh, I know.
As I said, you cannot do this without these things. It's not possible.
And how much did that cost?
This is a great system, I have to say. I mean, the other systems, this one cost $250, about $20,000.
$20,000. And spell what would be the website? www.what?
ZU.
ZU. Spell. You mean Z?
Z. Yes. I'm sorry. You guys say Z. We say Z.
You say Z?
Z. Yeah. In England they say Z.
Okay. Z.
ZUMAX.
ZUMAX.
Yeah, Zoomax.
Yeah, and the British call the letter Z a Z?
Z, yeah, that's it.
Z. Is that where Led Zeppelin comes from? Oh, so yeah, that is just amazing to look through.
That's full HD. I mean, that's got full HD capacity. So we have, a feed onto an HD screen. So this is the full package. I mean, this is not just that's $20,000 for the full Monty.
And what country makes that?
Would you be surprised if I said China?
Really, China's making those.
Yeah.
Fantastic. Mark,
I'm pretty sure it's China. Put it this way, it's somewhere in that region, but yeah. I'm pretty sure it's from China.
Actually, when I go into dental manufacturing companies, you really can't say it's made in that country, because when you talk to any country, anybody making anything, they say, well, yeah, we assemble this bonding agent, but this chemical is from Switzerland, and this chemical is from Sweden, and this chemical, from Japan. So all the ingredients, but they say 30,000 components are assembled in a car, and they come from literally 50 countries when they assemble a car. But a lot of dentists I know, in fact, the closest friends I know in just my neighborhood, in my zip code, 8504, who actually bought that scope or bought a microscope like that, actually did it for their neck first. They just couldn't lean their head over anymore. They had so much back pain, shoulder pain. They did it for ergonomic reasons. Have you?
100%. I mean, it's like, if you look at the posture and your position, I mean, it's, we have to look after ourselves, as guys who are getting old. But it's an amazing how much better you feel after a day of microscopic dentistry. But I have to be honest, for the restorative dentistry that I do, I still have my loops. I work between the two. I wouldn't say that I do absolutely everything with a microscope.
Right.
Maybe I haven't been using it long enough. It's quite new in my kind of work procedure, but it's a great tool.
Yeah, I'm always thinking of what is the most controversial thing I can ask you. So I'm going to go. This is the next one.
Go on,
Well,
you
well,
find one.
well. What I like about it is, the whole mission of Dental Town. When I saw the internet come out in 1998, for me, I said, no one ever has to practice solo again. So I like to, these dentists, and the reason podcasts are so popular as opposed to like
Yeah.
a lecture is because they're
Yeah.
multitasking. They're
Yes.
listening while they're driving to work. They're listening while they're commuting on the
Really,
train to work.
I love the idea. I have to say, you've done some great ones, and I've listened to a lot of them. So well done.
Well, you were a member of the American Equilibration Society, and I can't think of anything more controversial in dentistry than occlusion. I mean, some
Oh,
people, some people
I was
almost
hoping you
think.
can ask me that.
Many
Yeah.
dentists say that occlusion is the religion of a dentistry. Everybody has a different god. Everybody just believes things, and they can't prove what they're saying. Why were you a member of the American Equilibration Society, and what are your thoughts about occlusion from 1981 to 2015?
I think that I've simplified the whole idea of occlusion over my time that I've been working as a dentist. I think that we used to look for problems in occlusion that often weren't there, is my first thing I would say, is we really tried to make it difficult for ourselves. So, I think these days there's certain things that if we're doing rehabilitations for patients, that we do relatively a large amount because of all the wear cases that we're seeing. I think certain fundamentals that we need to look at are that we need guidance. We need some sort of guidance system. Canine guidance is the greatest, and anterior guidance needs to be established when we're providing any anterior restorations and posterior restorations for that matter. I think a lot of cases fail because the guidance issues haven't been dealt with. The big debate about centric relations, centric occlusion, I think that I have to say that I've restored a lot of cases in centric occlusion. Of course, you have to look at centric relation and see where it is in relationship, interferences, eliminate interferences. I think that obviously you have to do a full TMJ workup and see is there any pathology. But I think that if ever I've made a mistake with occlusion, it's because I tried to look too deep into it and to find problems that maybe necessarily weren't there. But I think that if we stick to the rules, things like vertical dimension have always been controversial. But there was a great paper that was written by Frank Spear, and he absolutely, and I there are a few people over my time that I have respect for, and he's one. His feeling was that, for instance, there are multiple vertical dimensions that patients can function at. There is not one vertical dimension. But just to change it because you want to change it isn't a good thing either. So use it if we need it. And we do often in wear cases where we don't have space for restorations. But, I think that keep it simple, but 100% we need guidance. You need good anterior guidance if your cases are going to last. There's no question.
Frank is actually about 30 minutes up the street from me.
Okay.
And he has done some of the most stunning.
He's a great guy. I mean, he's a smart guy. He's a great teacher. I have a lot of respect. There are a few people who I look at and I think, okay, those guys I'll listen to anytime. And he's really probably on the top of the list, I think, as an educator and just a good mind, someone who actually sees things in quite a clear way. And the other thing I think when it comes to occlusion, I think, the occlusion and the wear and the bruxism and all these things come hand in hand in managing these problems. I can personally say that I destroyed my teeth, over a period of time, whatever it was, but I don't feel like I had interferences. Yes, I lost my guidance, but I think that there's certainly an element that of a kind of psychogenic nature to bruxism, and we have to, as I say, as a result, build in good guidance patterns for our rehabilitations. Otherwise, they're going to fail. And I have to say that sadly, or not sadly, but we have to educate our patients that night guards and wearing of night guards is really a smart thing as well, you know, whether we like it or not.
What would you say to some of these non-dental groups out there in the world, evidence-based people, evidence-based epidemiology, things like that? They're saying that that they think there's a stress psychosomatic component to 5 things: migraine headaches, TMJ, lower back pain, irritable bowel, and heart beating irregularities. Do you think there's a psychosomatic stress association to grinding your teeth, or do you think it's purely mechanical engineering occlusion?
Yeah, no, I have to be honest that my feeling is that it's multifactorial. So I think there's a number of different factors that come into play when we look at bruxism as a problem in patients. But 100% there's a psychogenic element that's involved there, you know, and an habitual element. You know, whether it's psychogenic, but it's an habitual thing.
I don't know.
It's not a mechanical problem that your teeth don't fit together properly. I don't believe that.
My teeth are worn down.
It's made worse by your teeth not fitting together properly, but I don't believe that it's purely because your teeth aren't fitting that you grind them. I don't believe that.
I don't know when I grinded my teeth, because I spent the first half of my life drinking beer and chasing women, and then I wasted the other half.
Yeah.
So I don't know which half I did.
Maybe it was somewhere in the middle.
Small attempt at a joke. So you also, I mean, you're a man who wears many hats. That's probably an understatement if I ever said one. You were also a fellow of the International Congress of Implantology. You're a registered ITI speaker. Are you just doing cosmetic dentistry, or are you placing implants, or are you only restoring them, or where are you at with implants right now in your journey?
Yeah, listen, I started placing implants back in 97, which makes me pretty old. But you know, I think that what I've learned as I've got older is that stick to what you know best. You know, and I think that if you look at dentistry and you're going to embrace certain other aspects like the orthodontics, and you know, we do a lot of smile design cases. I can't keep up to date with the implant side of aesthetic dentistry. You know, that's moving so fast. I work with, as far as I'm concerned, and you know what, you got to try and get him on because he's hilarious and he's so smart, this guy, with probably the best implantologist in the world, Howie Gluckman. And, you know, he's a magician when it comes to soft tissue and bone regeneration, you know, which most of our cases need. I absolutely, you know, I can't do it like he can do it. And you know, we have high aesthetic demand cases. Our patients are smart. They know exactly what they want. And so I think you have to surround yourself with people like that if you're going to achieve the right results. You know, otherwise there's a compromise somewhere. So yes, I used to place them, but not anymore. I placed some really easy ones, put it that way.
In just the United States, for anybody working on another human body in healthcare, you know, just doctors only working on the human body, there are 40,000 different monthly journals.
Oh my goodness.
And I know that because I have a dental magazine, Dental Town, so I see the list. But I would go back even further into implants. I mean, just to keep up on bone grafting would be a full-time job. I mean, bone grafting alone is.
You know, we've been doing some amazing work. For instance, like partial extraction therapy, where socket shields. I mean, we're leaving roots behind in edentulous places. You know, we're preserving bone like we never used to preserve bone before. There's no question that our aesthetic cases, I think, are going to be much more sustainable long term than ever before. You know, and it's moving so fast that I think you have to focus on one area of dentistry. And I kind of chose more the restorative side, not the surgical side. So, you know, we have a great partnership. I do the design, Howard does the surgery, and then I follow up with the restorative work at the end. And it's a team. You know, there's no question that these cases can't be solved by one person. It's not possible.
Well, we would love to interview him on a podcast, and we'd also be beyond honored to get an online CE course from you guys, so you can.
I will make it happen. I've got this big conference, I mean, I'm running a big conference in 6 weeks' time. When I get that out the way, I'm all yours.
We put up, I forget the number, I think it's 347 one-hour courses, and they've been viewed over 500,000 times, 550,000 times.
That's fantastic.
But I want to go into this deal. Okay, so bottom line is you're talking to a lot of dentists who might think they do cosmetic dentistry. They're aesthetic dentistry because they do some cases, but they've never ever used a digital smile design. Talk about a digital smile design and how digital, what is it? What exactly are you using? What software? And how does that help you be an aesthetic cosmetic dentist with digital smile design?
Again, if I think about the things that have changed the way I work, and the one thing for sure is digital smile design. It came about 5 years ago, 4 or 5 years ago. I met up with Christian Coachman. In fact, I was first exposed to it by Philip Gurel at his practice in Istanbul. And I have to be honest, the first time I saw it, I thought, okay, this is pretty cool, but it looks like a little bit of a gimmicky thing, and I'm not sure that it's going to stick around. But, wow, I must say that I'm absolutely 100% convinced. We do it for every case, whether it's a two teeth, full mouth rehabilitation. It's the starting point of the treatment planning. I think the key thing about treatment planning is facial integration. Is that I can remember the times where you were given models and x-rays and you were told to treatment plan. I cannot do a treatment plan without looking at the face. The face will control the rest of the diagnosis or the rest of the planning situation. So we have to, it's a facially driven treatment process rather than a tooth driven treatment process. So we integrate really the teeth with the face, and then we move it forward. And I think that what it does is it allows us to work out so many different parameters, that need to be thought about in the planning process. And the workflow, I think that we all know it is that the DSD or the digital smile design eventually takes us to a wax up. But it's a very detailed wax up that we've not just asked any old lab to make 6 teeth with wax on them. This is a wax up that's been driven by the face, and we've determined where the teeth need to go. And from there you can start to answer all the other questions about bone grafting, about periodontal, about orthodontics, and then it provides us with a communication tool to speak to the other members of maybe a multidisciplinary treatment case. So there are a huge number of benefits from using DSD or digital smile design in a treatment planning case, in a case. Case presentation, I mean, there's so much that we take from it, and kind of once we have the outline or the mock-up or the whatever you want to call it, and you're happy with everything, then it makes the rest of the treatment process quite simple, because really you're taking a design that you've agreed upon, maybe the team, you and the patient, and you're just moving it through from the beginning to the end. So it's a simplified process of a treatment protocol.
My mother told me I had a face for radio, not TV. So
you look pretty good to me, I must say.
So what brand of this digital smile do you use? Which software?
No, well, I'm sort of not affiliated, but I am about to become affiliated with Christian Coachman, and so I go down their school. I use their philosophy and their methodology and their software. I think that those guys are really really unbelievable thinkers, and I mean I think they've done a great job for this process.
And tell us about your meeting coming up. What type of speakers are you bringing in for, and why are you bringing them in? I mean, are you bringing in implant people? Is it smile design? Is it cosmetic dentists? What do you think? What's hot and what's not right now? Listen,
I mean, I think that from my side, I think that we've probably been exposed to a lot more implant dentistry over the last 5 to 10 years than other aspects of dentistry. So I think that some of the orthodontics has been, I think that we're bringing in, that's been left out. So we're trying to bring that in for sure. I think that aesthetic dentistry is multidisciplinary. So I don't know if you know about South Africa, but the theme of our meeting is the Big Five. Okay, and really that means the Big Five. Not the animals, but restorative dentistry, surgical dentistry, orthodontics, perio, and even endodontics. So we're bringing in all the disciplines. But
for our viewers who have never gone, I went to the Serengeti last year. Explain what the Big Five is. That's a lion, elephant,
buffalo,
leopard,
and rhino.
I'll tell you what, I thought the Serengeti. I mean, I literally was speechless for 2 days.
I mean, you know what? You cannot. When I talk to people about going to the bush, I say, do you know what? I'm not even going to try and explain it to you because I won't do it justice. You got to get there and you got to sample it. It's the noises, it's the smell, it's just something you have to be there to experience.
I swear, I'm 53 now. I'd lived half a century on this planet Earth. I had no idea there were places like that still existed. I mean, you hear about it until you get there. You're like, oh my God, I cannot believe it.
That's unbelievable.
The weirdest thing, I still remember the weirdest thing ever is we were doing something and I was looking at a tree and then I realized camouflaged in that tree was a giraffe that was about 20 feet tall, just looking at me. And it's like I was staring at that tree probably for a full couple of minutes before I realized there was a giraffe in there looking at me.
It's amazing. It's kind of something that, if you had a bucket list, that's got to be at the top of the list, to go to the bush and to the real bush, African bush, not kind of African bush. Serengeti's right up there. It's great.
And what would be the best safari to see in South Africa?
What's the best safari?
Yeah, or best place, best park to go.
I think that we have a place called the Kruger Park. Which is a huge. It's kind of a government-run park. It's for the people. It doesn't cost a lot, but bordering on that whole area are private parks. So we have options really for all budgets, which is really a cool thing about the game reserves in South Africa. They're not just for exclusive people who have got a lot of cash. So. I think it depends what your budget is. If you tell me what the budget is, I'll tell you where you need to go. But we have so many options, I have to say. There's no shortage of really, really good game reserves in South Africa, that's for sure. And then, of course, we have, Botswana, Namibia, and Zambia. We have so many other places, which have also, pretty cool places to visit.
So let's switch gears completely. For international viewers around the world, what is it like being a dentist in South Africa? Meaning things like, do you have water fluoridation or not? Do children drink a lot of soda? Do you have a lot of pediatric decay or not? Or what is it like being on the what's public dental health like?
Well, put it this way. I think that I'm not really. I have to be a little bit careful because. Two things that really, I'm in a very small niche of dentistry, so I'm not really exposed to, kind of run-of-the-mill dentistry we're talking about. But one thing's for sure, I know if you think about the population of South Africa, and it's like over 50 million, I think we have only 3,500 registered or just under 4,000 registered dentists. So you can do the maths quickly. We have a huge shortage of dentists in this country. And I think that the areas that would get affected most are the low socioeconomic areas. So, I think for sure we have a lot of poverty in the country. And I think that, the basic dental needs of people is is neglected to a degree. So I think it's, I think dentistry in this country, we have, such a big spectrum. We have the best dentists in the world, but equally we have a need for, basic dentistry, which I think is stretched, to be honest.
It's amazing how Africa now has, the continent of Africa has 1 billion people, which is over on this side of the Western Hemisphere, North and South America combined have 1 billion, but Africa has as many people as North and South America. It's a huge country. Just amazing. It's amazing to see a map where you can take the United States of America and you can set it down in the Sahara.
And listen, I think that if you worked out how many dentists were in Africa, you'd be absolutely shocked. At the kind. This is the population for each dentist, and it's not manageable on that scale. That's for sure. I can't give you the figures, but I know, look at South Africa's model, and we have I think way more dentists per capita than any other country. So I think it's we're not, the universities aren't, there aren't enough dentists qualifying, and a lot of guys left the country. I have to say that's another issue. So that's a whole.
You're also president of your South African Dental Society, of the Aesthetic Dentistry Society.
That's right. I'm actually just become the past president last week or 2 weekends ago.
So now you got some more.
I was the president. I was the founder and the president for the last 3 years
of the South African Academy of Aesthetic Dentistry.
That's right. I founded the academy in 2010. And so we've done really well. We're responsible for a lot of postgraduate education. We hold a lot of courses. We hold a lot of study groups. We run a lot of meetings. And so it's a big gap that we've filled.
So do you like? Are you using, or do you like CAD/CAM?
I think CAD/CAM is great. I think that I'm not using it at the moment. I use it indirectly through my laboratory and through the orthodontic process, where we use digital workflow, but I don't have a CAD/CAM machine in my practice. I had one for about 4 months. 100% we will be using CAD/CAM in the near future. I certainly will be scanning in the future. Whether I'm the person who's going to be doing the milling and staining and glazing, I'm not sure yet. But for sure, CAD/CAM dentistry is here to stay. It's the future of dentistry. There's no question.
I find myself, I started in '87 with CEREC 1, then I went to CEREC 2, then it was CEREC 3, then it was 3D, then it was Bluetooth. But I find myself more and more just using the scanning portion of it and sending
that's for me. If I look at it where it is now, 100% I want to scan. I'm not sure that I want to be the guy doing the laboratory side. I think that there are a couple of reasons. Is that I don't have the time at the moment. Exactly. My book is completely chock-a-block. I'm good at what I do. And I have to be honest, I like, my technician can do work that I can't do. He's been doing it for 20 years, and he knows more than I do from a technical point of view. I'm not going to learn his skills in 1 month or in 2 weekends or whatever it takes. It's going to take me so long to get as good as he is. And so, I love the scanning idea, and I love the ability to integrate the DSD, the concept now of DSD, of taking a scan, taking a photograph, all the photographs, and taking a cone beam, a CBCT, and integrating all these assets into one. And from that, doing a design and working out a treatment plan, and out the other end comes the orthodontic appliances, the surgical stent for the implants, and the prosthetics for the patient. It's like, it's another world. It's just so exciting, I have to say.
Yeah, and you just have to have a lot of extra operatories to be able to give up an assistant for an hour or two to go finish milling, designing, staining, glazing, whatever. And so many times I need that assistant for an emergency, a toothache, another deal. And if I say to a guy like you, a typical businessman person in the office and say, hey, Mark, you could either stay here today. I'll just keep you 1 hour. We'll numb you up, prep the tooth, take an impression, and you'll leave in 1 hour. Then you'll come back in 2 weeks for 30 minutes. Or we can do it all today, but you'll stay for 2 hours. Do you want an hour today or 2 hours a day and be done with it? 9 out of 10 people tell me, I mean, they're busy. They're like, oh, yeah, an hour. Yeah, I'd rather come back for the other half. Because they're looking at their calendar, they're looking at their texting, they're looking at their workflow, and they don't want to spend 2 hours in there. And I don't want to have one of my 4 killer assistants tied up in a room for 2 hours. You know what I mean?
I think there's pros and cons. I think it's not a clear argument. Like, I think each person has to look at their own skills and their own practice and the sort of patients they're treating. I do a lot of anterior cases, which are highly demanding. In saying that, we do a lot of restorations, which are full press. In other words, monolithic, that aren't layered, which are just stained and glazed, because I'm a big fan on the staining, glazing, monolithic porcelain from Emax. But I can't do what my technician can do. That's what it comes down to. He understands the laboratory side of work in a way that I don't. And I don't see myself having the time available to learn his skills. Correct. I see that as a waste of time. But I think if you had a practice where you were doing lots of single unit posterior restorations, partial coverage, I think that's a great option.
Right. Yeah, and like everything, I notice on guys our age, when you're young, everything's black and white, yes, no, right, left, up, down. And one of the first questions I asked you about TMJ and is there stress related, you said, well, you think it's multifactorial. And as you get older and older and older, nothing's black and white. Everything's 50 shades of gray. Everything's multifactorial. Because when you're young, you're looking for an answer, and you're like, am I supposed to go right or left? And when you're half a century old, you're like, well, there's a lot of paths you can take here. There might be 20 different paths you can take here. So about lab, do you use a lab in South Africa, or do you ship it international, or how?
I use a lab in South Africa. I have a great technician that I work with pretty much on all my cases. I have one technician that he understands my language, and I understand his language. We communicate well. We have a great understanding in how we manage and manage our cases, and so there's no need for me to ship them out, to be honest with you. I think that the skill level in South Africa is high, for sure.
On orthodontics, are you using any clear trays like Invisalign or ClearCorrect or any of that stuff?
Yeah, we use clear aligners in South Africa.
Do you do that yourself, or since you're a cosmetic guy, or do you have your orthodontist do that?
No, I do it. I do. I will say that I only treat adult cases, so I don't treat any children for orthodontics. I think the fundamentals are quite different, in terms of what we're trying to achieve and what we're not trying to achieve. So I think that you have to understand. And so, yes, we do a lot of aligner cases, whether it's a kind of a spring aligner or an Inman type aligner, an Inman aligner, or clear aligners. I'm a big fan of these, just even pre-orthodontic movement for restorative cases. For wear cases, it's awesome. We have no space for restorations. I don't want to cut teeth. I'll move them to make space for the restoration. So I'm a big fan of integrating orthodontics into the practice, for sure.
And that has really been the biggest change I've seen from getting in. I started dental school in '84, and it was just like everything with these big monster burrs, and how fast could you prep down a teeth, and there were just people out there that would brag about how fast they could prepare a tooth, and basically hitting it with a chainsaw. And now 28 years later, you just we realize it's just minimally invasive. It's like that, saving the enamel, saving the tooth structure, anything you can do.
It's not another way, it's the only way. It is the only way. There is no other way. And that's kind of the mindset And I think, I'm not sure, and I might get into some hot water here, but I'm not sure what the approaches at dental school these days is to the education process. Is it on a minimally invasive, or is it still old school? I'm sure that really the attention needs to be, teaching these guys from day one that this is the way it needs to be done. And I'm not sure that's the case.
It's funny because I get so many viewer fan mail and emails from these podcasts,
Yeah.
and so many of them tell me that they listening to the podcast or they're on their iPhone reading Dental Town in the back row of a boring lecture in dental school. They go, when I'm not learning anything in the lecture, I just go to Dental Town and read during class.
You know what? I mean, I have to say that what I really enjoy when I do cases like this, like the ones I do, is really educating the patients, giving them the information and making, I learned this concept about raising a patient's dental IQ. I think I got it from one of my American mates, that, if you can raise a patient's IQ for dentistry, anything is possible. I can't tell you the number of times where I see something, we did it like this because the patient refused XYZ. I don't buy into that, I have to say. That if you give an intelligent person all the right options, I don't believe that they will refuse something to have their teeth cut down. That's my opinion.
So then, bottom line, is this digital smile design, is that more to help you do your aesthetic dentistry, or is it more a patient communication of getting the patient on the same page? Do you think it's a more patient-focused technology or a dentist-focused technology?
I think the benefit is for myself massively. It's for the patient also in a big way. And it's also a communication tool to any other of the clinicians that I'm working with. So, for instance, if Howie Glackman, friend, the periodontist, has a case and he's going to plant some implants, he wants to know where the implants need to go. So he'll send the patient to me, and I'll do a digital smile design, because that will then determine that we put in now the teeth in the correct place from a functional and an aesthetic point of view. And once we know where the teeth are going to go, then we can decide where the implants are going to go. That's the order that it has to be done. And then you can explain to the patient why maybe they need some periodontal surgery, or they need a bone block, or whatever it might be. Because if they want their teeth in the right place, we have to put the implant here. We can't put it over there, because we put it over there, which is the easy option, possibly, the teeth are going to be in the wrong place. And there's going to be a functional problem, and there's going to be an aesthetic problem. So it's kind of the driving force behind the treatment planning that goes on. And so, I can't imagine doing a case without it anymore. I've done 200-300 cases now. And, some of them are quite simple, I have to say. There are some cases you can eyeball and you can kind of see what needs to be done. But there are some complex cases that come into our surgeries where there are a multitude of problems. And you need a starting point. If you kind of start to think about too many things all at once, you get confused. So this simplifies the process of where you start and where you finish. And it becomes a controlled way. And I think that the thing that comes to my mind is we become more predictable in our treatment, in our treatments that we provide patients, because of we understand where we're heading. The end result is already decided before we start. And I think that's where, it's made it so much easier for me.
Well, like they say, if you don't know where you're going, you'll probably get there.
Yeah, it might be painful though.
You're right.
Might cost you a lot of money as well.
Well, I just want to, it's now 9:30 at night there, and you're a legend, and it's just so dang nice of you to stay up for an hour after a long day of work to spend talking to me. I just think you're a hell of a guy. You're a hell of a legend. So many of my dentist friends just think you're the absolute bomb, and I think you are. And I just want to say, from the bottom of my heart, thank you so much for spending an hour with me.
Cool. And we're going to be sharing a podium in South Africa, I believe, possibly next year. Is that right?
That's right. And what I was also, yeah, and what I was also thinking is, we have an annual townie meeting for the townies. There's 202,000 townies. I think someday we should put on our thinking cap and try to mix of a clinical dental continuing education while they can get out there and see some of these game parks and reserves.
They would love that, I have to say.
Yeah, make it a business expense trip where you can go and learn from legends like you and then get out there and see some Big Five game.
So you're going to get a chance to go to the game reserve when you come out to South Africa next year?
Absolutely. Absolutely.
All right. Well, if you need some recommendations, you speak to me, send me an email, and I'll tell you where you need to go if you want. That's no problem.
Absolutely. I think Africa is absolutely has to be the most beautiful continent on earth.
It's extraordinary, I have to say. And you know what? I'm so lucky that we live in the most beautiful city in the world. I'm in Cape Town, and I'm not biased because I live here. I promise you, you come here and, every day I drive past the mountain, I look it up and I think, oh my goodness, that's just the most beautiful place.
I climbed Kilimanjaro last year.
Okay.
And just to go out there with no cell phone, no work, no phone, just completely unplug from the world and then go out there.
That's a great experience. I did it about 6 years ago.
Yeah, that's
not
amazing. Okay, well, thank you so much for your time.
You too. Thank you so much.
All right, have a good evening.